Kia ora koutou, Vanessa Caldwell from Maturaki Addictions Workforce Development. At the risk of repeating a lot of what's said, I do want to emphasise a few things from a workforce development perspective. You'll have to forgive me, I've just got and another sign that I'm no longer a youth, got my first pair of glasses this week. So if I look startled when I look up to you, it's actually because I can actually see you now. So I think we all know that things need to improve, and in fact there's not one person that I've met or talked to in this sector that doesn't want to see things get better or be done better. We all want improved access to support that's closer to home, service improvement that achieves better outcomes for young people who experience problematic substance use. And in fact we've heard a little bit about this morning about how treatment does work for young people. And you might be right in suggesting that, of course, we're going to say that. The truth is, we've not had to demonstrate our effectiveness of what we do and how we work. The truth is, we've got reasonable ideas based on research and our interactions with the people that we work with, but actually we don't know what we do, how it works well, and what doesn't work so well. We haven't had to measure it in any way. We haven't had to have robust data collection methods that allow outcomes or consumer feedback information to be collated in a meaningful way beyond each individual client measuring their own levels of improvement. I would like to suggest that this needs to change. For us to really be in a confident position to understand what needs to be improved, we need to be clear about what's currently working well and what isn't. And really, if we don't start collecting this information and using it wisely to make some decisions about service delivery and design so that we achieve the kind of level of consistency across the country that Grant was suggesting, we will be standing here in another couple of years having this same conversation. We've tended in the past as a sector to tweak things here and there and hope that it's going to make a difference. But both the key documents that we're referring to this morning actually signal that we do need to make some changes. I think a lot of our inertia in making significant changes to our system of delivery is simply because we genuinely don't know where to start. We don't know what to keep doing and what to stop doing, which is actually much more of a challenge, I think. We do have some tools to do this. And we've got some plans to assist services to implement an adult outcomes measure on a voluntary basis initially over the next year or two. I think it would be great if this was extended to youth-based services as well, although it's really clear that a lack of IT platforms suitable for this kind of exercise is a big impediment as it is for adult services. Beyond the IT challenge is the challenge of actually understanding what's being measured, and for young people, as we've heard a lot this morning, it's never just about the alcohol and drug use. It is complex, but I think we need to make a start. Increased access doesn't necessarily mean just more resources for more specialist services. It does mean making better use of our frontline resources in our allied sectors. Early intervention initiatives such as implementing the HEADS assessment tool, which has been identified as a key instrument in early identification of mental health and alcohol and other drug concerns, is being led by the Wherry Centre. It's important this tool can be accessed by the primary health workforce, so target audiences for this training will include school nurses, school counsellors, youth workers, practice nurses, GPs and social workers. It's hoped that this training will assist in appropriate referrals to addiction services and those services offered in schools such as those like WellTrust, and increase resourcing for those programs which bring the help to where the young people are. We can't expect to continue to operate youth services in the same way we do for adults, and it's great that we've had some good examples this morning of some youth-focused services. However, if we continue to do a lot of the same stuff we are now, it's quite easy for us to mistake, for example, things like motivation for treatment, which is actually much more a factor of how able a parent is to motivate a young person to get in the car. In addition, SACS BI training for those involved in Fresh Start, for example, have also increased the number of frontline youth social workers who are competent in screening for AOD issues. Screaming, probably. And providing some useful strategies for problematic substance use. Increased use of specialist workers as consultants for those working in primary care sectors will assist in increasing the level of confidence people have to engage with young people about their substance use and encourage them to have those challenging conversations. It's not about having new roles, it's about us actually bridging that gap to the primary health sector and giving them the confidence to engage in those conversations with young people. However, this is only, I think, part of the equation, because if we encouraging many more people to screen for issues, we have to actually build our resourcing to respond to those issues when there is significant problems identified. I can tell you now that the minute a GP goes to the effort of actually doing a screening tool for an alcohol and drug use for a young person, finds a significant problem, tries desperately to contact a service, only to have to wait months to see somebody, or gets bumped around for different services, or they're not in the right place, they'll never use it again. The confidence is gone. So we have to do both at the same time. We have to build our specialist services sufficiently to be able to cope with that increased demand. Lastly, but not least, I think we can't continue to punish young people for drug use by taking them away from the very place that's likely to be the key stabilising and protective factor against long-term problems, and that's their school. While I fully appreciate the challenge, I think if we do work collaboratively with a young person's best interests foremost, more effective solutions can be found. Yes, it might involve more people. Yes, it might involve more resourcing. Yes, it might involve more creative solutions being found and an increased effort. But if we don't think they're worth that effort, how in the hell are they going to believe they're worth the effort? How are they going to believe they're worthwhile? What is a while? It's time. If you've got to feel you're worth somebody's time. And I think it's our collective responsibility to show that these young people that struggling with substance problems, that they are worthwhile and they're worth our time and effort to put into making a system that works well for them. Ministry of Education stats tell us over 1,000 students in this country were suspended or excluded from schools last year for drug or alcohol use. 1 in 10 of these children were under 12, the youngest being 8. This occurs throughout the country and is irrespective of decile or socioeconomic status. We know that many of these young people are simply bringing to school what's happening at home, and we've heard a few stories about those, the reality of that this morning too. We know that many of them are surrounded by alcohol and drugs. It's part of their everyday lives. For some, it's what mum's blown in their face to get them to sleep since they were babies. It's what puts food on their table. It's what they do together as a family. And we struggle to know how best to manage it when it becomes a problem at school. But keeping them away from school, which might seem optimum to keep the majority safe, is going to do nothing to address the situation that those young people face. And I know that there's often a lot of agencies that are involved at that point, but they're generally not well coordinated, and we know that, as much as our best intentions. And any involvement in addiction-related services is done with the individual person, the young person. I think rightfully so, things have to be pretty bad for a specialist addiction service to be involved, but unfortunately, there's not much of anything in the gap for anybody who has not quite an addiction or for who has a family with addiction problems or who have parents known to have addictions. There are a number of initiatives that are currently underway, including the Heads Assessment Training, which, if implemented in a well-coordinated way, will improve some access to screening for AOD issues. and provide some much needed resourcing before specialist services get involved. And in addition, there's the adaptation of COPMEA, which is the Children of Parents with Mental Illness and Addiction programs, which we're going to adapt for the New Zealand context, which will also help provide some supporting information for the primary care environment. But young people need to be seen in the context of their families. And as a whole, the addiction sector is not set up well to work with families or groups. Working with families and seeing families as part of the solution rather than part of the problem, I think, is sadly lacking in training of addiction practitioners, despite strong evidence that involvement of families in treatment not only reduces relapse, but also reduces the familial stress that often create situations for relapse. So we need to focus, I think, much more on family inclusive practices, making family friendly environments, and as practitioners working hard to be comfortable in working in family environments. The more that the artificial barriers of our health sector groups are respectfully broken down in order to work together, the more likely appropriately integrated services will be available. And we've talked a lot about that this morning. It does involve collaboration. It involves us actually breaking down those barriers. Supporting cross-sector relationships and links to be developed and enhanced will lead to us being able to provide holistic care that addresses what's really going on for the young person, and it's that whole of person care that many of us strive to achieve. We've talked a bit about making use of technology to encourage young people to engage in early intervention strategies and assisting them to make positive choices and offering support. There are multiple ways we can use that. I think it's a signal of our ageing workforce that we're a little bit hesitant to go there, but I think we need to. Developing apps that can be downloaded to be worked on in their own time, online groups, e-therapies, text alerts are all in their real infancy here, but we need to do some more work around those things and promoting them and feeling comfortable about engaging with young people in those tools. So in short, there's no quick fixes. We know that, otherwise we would have done it. But there are some solutions to increasing access to addiction services for young people. The success of those, however, I do think relies on everyone being involved through active participation, sharing information, good referrals, and seeing other allied providers as supporting the care of the young person, supporting the work that you're doing rather than as competitors. So our ongoing work and support of each other is going to be a vital component to this work being successful, and I think these young people are worth that effort. Thanks.